Good evening, everyone. Welcome to our Fireside Chat number 154 this evening. My name is Dr. Mazur, Country Medical Director and Chief Medical Officer for HN. Today, we'll be having a talk by Professor Prakash Gudsoorkar. He is an Assistant Professor of Medicine in the Division of Nephrology and Kidney TARE, which is Clinical Advancement Research and Education Program at the University of Cincinnati. After completing his internal medicine nephrology training in India, he pursued nephrology and transplant fellowship at the University of Toronto, Canada. He joined as a faculty at the University of Cincinnati in February 2020. His area in clinical and research interests are quality improvement in acute kidney injury, home dialysis modalities, and onconephrology. He is currently pursuing a master in clinical and translational research, the principal investigator track. He serves as the editorial board member for Advances in Chronic Kidney Disease Journal, member of Position Statement Education Committee for American Society of Onconephrology, mentor for the International Society of Nephrology Partnership Program, faculty mentor for Nephrons, and medical advisory board for National Kidney Foundation Ohio chapter. I must say that of these three, at least two of them I have used in my residency program, especially the NEPSIM programs online. So that was very, very grateful and it was very helpful as a fellow. And with regards to the National Kidney Foundation, I frequently visit the website to try and make talks for our community members that are non-medical field. So it's a privilege to actually have a faculty member on today. And Professor Gudsoorkar will be taking us on to acute kidney problems in cancer patients, a case-based approach. Prof, over to you. Thank you.
Thank you so much, Dr. Mazar. Dr. Vincent, everyone, thank you for having me for the second time here regarding a topic and the subject which I'm very passionate about. So I'm going to share my slides. Let me know if you are not able to see them. This is just a part 2 of my talk. I don't know how many of you attended my first talk. It's, I think, available on the YouTube channel. But today I'm going to focus specifically on the nephrotoxicity of the cancer therapies and how we approach them and how we manage them. I'm going to talk about, it's always good to go through the cases which I have encountered during my clinical work, and then we'll gradually, I'll walk you through all the cases, whatever we talk about. I'm not going to talk too much on myeloma. I'm not going to talk too much on kidney cancer at this point of time, because both of those topics are extensive and are separate talks and lectures on their own. So I don't have any conflict of interest regarding my talk. These are my disclosures. These are our learning objectives today. We'll go through the various drugs which affect on the various parts of the nephron, that is the glomerulus, vascular compartment, interstitium, podocytes, and the tubular architecture. We'll try to describe the spectrum of acute kidney injury from conventional oncotherapeutic agents. We'll talk about the acute kidney injury from immune checkpoint inhibitors, and we'll also summarize an approach, how to manage the AKI associated with immune checkpoint inhibitors. And then at the end of it, we'll talk about a concept of pseudo AKI, or an artifactual rise in the serum creatinine, and what drugs can cause that. So this is actually a cartoon from one of our papers which we published in CJSON in 2022, which talks about the acute kidney injury in a nutshell. So you really see there are cancer-specific factors and there are treatment-specific factors which cause acute kidney injury in a patient. And then there are cancer-specific factors and patient-specific factors which predispose a particular patient to develop acute kidney injury. But if you can see, there are many times the cancer itself and its therapy also, they intersect and predisposed and increased risk of acute kidney injury in certain types of patients. So nephrotoxins, hemodynamically mediated acute kidney injury, which is one of the common reasons, obstructive nephropathy from gynecological malignancies, or retroperitoneal lymphadenopathy. Radiation therapy is a very important and often missed diagnosis in these patients. Infiltrative kidney diseases like myelomas or acute myeloid leukemias or lymphomas infiltrating into the kidney, causing acute kidney injury. But when we talk about the drug toxicity in relation to the nephron, it's always good to identify those specific drugs which act on the specific parts. But it is also very interesting that certain drugs which acts on glomerulus will also cause toxicity on the tubules. It can also cause a vascular toxicity. So there will be a lot of overlap of manifestations when these acute kidney injury happens. So I always like to remember a particular compartment of the nephron and the drugs associated with that. So when we talk about the vascular compartment, there are certain drugs like gemcitabine, doxorubicin, mitomycin, cisplatin, vascular endothelial growth factor inhibitors, Burton kinase inhibitors, which are increasingly used in the treatment of CLN. These called vascular toxicity. Then the glomerular toxicity or the podocyte injury, which happens because of certain drugs like vascular endothelial growth factor receptor inhibitors, epidermal growth factor receptor inhibitors, or immune checkpoint inhibitors. And one drug which we have commonly used in our transplantation is the mTOR inhibitors. Talking about the proximal tubule, the classic drug which we always talk about is the cisplatin and the carboplatin. Cyclophosphamide, ifosfamide. We all know these drugs, they do cause proximal tubular injury, and sometimes they cause Fanconi syndrome-like picture. Tyrosine kinase inhibitors like the ibrutinib. Talking about the interstitial compartment, the classic drugs which we are seeing nowadays is the immune checkpoint inhibitors, cisplatin, proteasome inhibitors, which are used increasingly now in treatment of paraproteinemias. Talking about the distal convoluted tube, cyclophosphamide, ifosfamide. And the collecting duct, which are classically known to cause crystalline nephropathies, are the methotrexate, pemetrexate, and certain conditions like tumor lysis syndrome, which necessarily is not a drug toxicity. So just remember this master diagram, which really sums up all possible drug toxicities. I mean, most commonly used drug toxicities in patients with cancer. I always like to highlight this study by one of my colleagues from Toronto, who did this very interesting study where they studied the incidence of acute kidney injury in patients receiving systemic therapies for cancer. And when they looked at their population in Ontario from 2007 to 2014, the cumulative incidence of acute kidney injury was noted to be 9.3. The highest incidence of acute kidney injury was seen in myeloma, followed by bladder cancer, followed by leukemias, and followed by kidney cancer. And obviously, like any other AKIs in a non-cancer patient, advanced cancer stage, presence of underlying chronic kidney disease, presence of underlying diabetes, increase the risk of acute kidney. On the right-hand side, you can see actually a figure which shows the cumulative incidence of the ESRD from the systemic therapies, the incidence of acute kidney injury, and incidence of death. But it's really an eye-opener to see the next chart, which is from the same paper, which shows the hazards ratio of the individual types of therapies which these patients have received. Cisplatin, very important for us. Hematopoietic stem cell transplant. These patients are prone to develop acute kidney injury by various mechanisms like the cyclosporin or tacrolimus, which is used in their therapies, or the bone marrow ablation therapy, which is used, or the radiation therapy, which is used, or they develop certain types of viral infections. They are treated with acyclovir. There are so many other reasons which causes acute kidney injury in hematopoietic stem cell transplant. Presence of acute leukemia and the treatments which are given for acute leukemia are make the patients prone to develop severe acute kidney injury. So let's talk about an individual cases. From now on, we'll go through each case and we'll talk about those particular cases. So this was a 55-year-old man who was diagnosed to have germ cell failure of testicle, no prior comorbidities, underwent an orchiectomy with retroperitoneal lymph node dissection. He undergoes chemotherapy. Nephrology is consulted for acute kidney injury with a serum creatinine of 2.1. Serum potassium is noted to be 2.8. Serum magnesium is 0.6. Serum uric acid level is 2.1. There is presence of protein 1 plus, glucose 3 plus. There is presence of heme granular class, and patient is non-onigural. What is the likely cause of such presentation and the metabolic abnormalities in this patient? So I'm not sure what units you guys use in the African region. Um, is it the millimoles per liter or milligrams per liter? If it is millimoles, I would tell you that there is an acute kidney injury. Patient's potassium is low, magnesium is low, uric acid is also low. The most common drug what we see in our clinical practice which causes this type of renal injury and metabolic abnormality is cisplatin. So how does cisplatin really cause an acute kidney injury? So this is a nice figure published in CJSON by Parazella from Yale. And this shows the way cisplatin nephrotoxicity how it happens. So cisplatin, it gets absorbed from the basolateral side to the organic cation transporter 2, and then is internalized into the proximal tubule. And then once it enters into the cellular architecture, it sets off a cascade of generation of reactive oxygen species, which causes mitochondrial damage, nuclear damage, and eventually the cell damage, or what we call as the tubular cell injury. So there are particular risk factors which dispose a patient for developing cisplatin-induced AKI. Presence of underlying chronic kidney disease, peak cisplatin levels, cumulative effect. The patient has been treated with cisplatin serially. The cumulative dose has a big implication on development of acute kidney injury. Concomitant nephrotoxins. The patient is treated with other agents like say acyclovir or vancomycin that increases the risk. Female because of the decrease in the total body water, old age, hypertension, hypoalbuminemia. These are all the major risk factors. And how does the manifestations of cisplatin nephrotoxicity, how does it present? It can present as an acute kidney injury. It can present with hyponatremia causing salt wasting nephropathy, hypomagnesemia. It can present as Fanconi syndrome with pantubular dysfunction, distal renal tubular acidosis, and in certain patients, it could be a relentless progression of the worsening of creatinine causing chronic kidney disease eventually. So this is not regarding this patient, but what I want to show is in a patient who's been treated with cisplatin and when Fanconi syndrome happens, this is the type of picture of amino acid urea one can see. This is actually from a real patient, not from the patient which I just described. This patient was seen by one of my colleagues at Memorial Sloan Kettering, and she provided me this figure. And you can see this is the urinary estimation of those individual amino acids. And you can see all those amino acids in the red color. The levels are increased, which means that there is presence of amino acid urea. So what are the long-term outcomes of adults who are treated with cisplatin? And this data comes from the MSKCC, that is the Memorial Sloan Kettering retrospective data, published in 2016. So if you really look at the patients, I'm trying to highlight here is the incidence of chronic kidney disease at year 5. So CKD stage 3, nearly 30% of the patients who are treated with cisplatin for various types of cancers eventually develop derangement in their GFR. So that's a big number actually. So if you look at at year 5, nearly 57% of those individuals, they develop CKD stage 2. So when you mix presence of hypertension, presence of diabetes, other comorbidities, the risk of progression of the kidney disease, as we all know, it progresses. So it's very important to critically follow these patients who have been treated with cisplatin, even if they don't develop acute kidney injury or any significant renal manifestations at the onset of the therapies, they are still bound to develop kidney disease later in their life. So this is very important aspect of the cancer survivorship program, which we are trying to propagate at our institute. So what are the principles in treatment of cisplatin nephrotoxicity? There has been no RCT, which has really looked at one therapy versus other. IV saline infusion, that is hydration of the patient, around the time when the patient is getting cisplatin is really helpful. Magnesium supplementation. So there is a clinical trial which is ongoing right now, which is looking at magnesium supplementation to mitigate the effect and mitigate the free radical injury effect, which can happen from cisplatin. Mannitol has been tried in high dose cisplatin protocols to help excrete the excess cisplatin out. However, the renal protective effect of mannitol in such scenarios has not been proven yet. Prophylactic dialysis to remove excess cisplatin, again, there is no role and no data to support that. And when we talk about kidney diseases now, we always talk about SGLT2 inhibitors. So does the retreatment with an SGLT2 inhibitor mitigate the effect of cisplatin nephrotoxicity down the line? I think that's a very interesting question. And there should be a clinical trial hopefully soon, but we really don't have a data to support that. Can patients who have developed chronic kidney disease and variable degrees of proteinuria benefit from SGLT2 inhibitor if you're attributing the kidney disease to cisplatin? Possibly yes, because all those patients anyways will be treated as your every other chronic kidney disease patient. And there is definitely a role of treating with SGLT2 inhibitor after the fact. But before the AKI happens, for a renal protective effect, we really don't have that data yet. Let's see the case 2. So this is a 50-year-old female, a very highly functioning female who has a full-time job, is referred to oncology because of non-resectable glioblastoma multiforme. She had some vague headaches, and on a routine imaging, it was noted that she has glioblastoma multiforme. And then because it is a deep-seated glioblastoma, they decide not to operate it and instead treat her with Avastin infusion, also called as the bevacizumab, which is a vascular endothelial growth factor inhibitor. She does not have any prior history of hypertension, has a normal kidney function, and she is referred to nephrology for evaluation of new onset hypertension and proteinuria. Blood pressure after initial 2 doses of Avastin is noted to be 170/100. Serum creatinine is well preserved. Urine analysis shows 3+ of proteinuria. Urine protein to creatinine ratio is 3.4, which is a significant amount of proteinuria. A 24-hour urine protein confirms the same. So what is the likely cause of the hypertension and proteinuria in this patient? Now, this patient really did not develop any acute kidney injury. So what we are talking about, a nephrotoxicity in a different form, that is hypertension and proteinuria. So let's talk about what has been happening in this patient. It's important to understand what does vascular endothelial growth factor does in to human body. So talking about the various vascular endothelial growth factors, that is the VEGF-A, VEGF-B, VEGF-D, all these eventually activate the vascular endothelial growth factor receptor. Once these receptors are activated, it sets off a cascade in which there is a vascular neovascular angiogenesis, which is important for maintenance of human health. But as you know, when there is a cancer growing up, the same vascular endothelial growth factor is utilized by the cancers to generate blood supply for its own benefit. So what does these vascular endothelial growth factor inhibitors do is specifically inhibit either the factor receptor or the factor itself and prevent the downstream effects. So what happens is when theoretically, if you are giving the bevacizumab, it will act on a VEGF-A receptor, which will downregulate the vascular endothelial growth factor receptor 2, and it will decrease the endogenous nitrous oxide. Now, endogenous nitrous oxide is a vasodilator. So when the nitrous oxide levels go down, there is relative increase in the endothelin 1 levels. Now, endothelin 1 in itself is a natural vasoconstrictor. So you are disturbing the vasoconstrictor and the vasodilator balance. That causes hypertension. It also generates reactive oxygen species. It causes endothelial rarefaction. It causes porocyte damage, which eventually leads to glomerular and tubulointerstitial damage, which again predisposes to development of hypertension and proteinuria. So you can imagine one particular drug really causing so many downstream effects. So these are the other receptors through which various other drugs act, that is the tyrosine kinase inhibitors, which are used commonly in treatment for hematological malignancies. They're commonly used for renal cell cancer. But what really happens at the microscopic level when patients are treated with these drugs? So we have always read about this thing called as the glomerular endotheliosis, which is commonly seen in patients who develop preeclamptic toxemia. But a similar type of lesion happens when patients get treated with vascular endothelial growth factor inhibitors. Just to compare, this is what the endothelial cell swelling appears on a microscopic image on a renal histopathology. On the right-hand side, you see the normal endothelium. So you can actually see the difference between the two endothelial cells. And then what you're seeing here in the center is the endothelial cell expansion or enlargement of the endothelial cell, also called as the endotheliosis. And this is the basis of the pathogenesis, which happens in preeclampsia and in similar way in patients who are treated with vascular endothelial growth factor inhibitors. And this particular type of lesion is commonly seen with ibrutinib, which is used in many of the hematological malignancies. How do we treat vascular endothelial growth factor inhibitor induced hypertension? RAS blockades. Again, there is no randomized controlled trial which has really looked at this aspect. This is based on opinion, and RAS blockers have shown to have a vasodilatory effect. It upregulates the nitrous oxide pathway, and also reduces the protein. Again, all this data has been extrapolated from the diabetic kidney disease. Dihydropyridine calcium channel blockers, again, they can be used because they decrease the smooth muscle contractility and enhances vasodilatation. Long-acting nitrates, similarly for the same reason. What do we avoid is non-dihydropyridine, like diltiazem, calcium channel blockers, because they cause hepatic microsomal enzyme inhibition, and because of that, the levels of the drug, the cancer drug, can go up. And diuretics per se are not contraindicated, but you have to be cautious because many of these patients, they may have accompanying cancer-related cachexia, nausea, vomiting, volume depletion, and are inherently prone to develop acute kidney disease. So this is a chart which is extracted from one of our recent publications, which shows the hypertension and proteinuria from anti-VEGF drugs. So if you look at the incidence of hypertension from these unique drugs is anywhere from 20% to 80%. So certain drugs like axitinib, which are used commonly in treatment for renal cell cancer or hepatocellular carcinoma, 40% hypertension. Cabozantinib, again 30 to 60%. Lenvatinib, 70%. So these are very unique drugs, which are very commonly used in cancer therapeutics now. And we as nephrologists will be seeing more and more incidents of hypertension and proteinuria and probably downstream glomerular disorders because of these drugs. Let's look at case 3. So this is a 50-year-old male who's diagnosed to have pulmonary adenocarcinoma with multiple bone metastasis. He's initiated on pemetrexed. So remember, pemetrexed is also an antifolate compound, which is similar to methotrexate, but with a better side effect profile. So Patient is treated with pemetrexate 500 milligrams meter square body surface area every 21 days. Vitamin B12 and folic acid are also administered. His serum creatinine before starting pemetrexate is 0.6. Now, after 2 cycles of pemetrexate, creatinine goes up to 3.2. Electrolytes are normal. Urine analysis shows 1 plus protein and normal. His urine protein to creatinine ratio is 0.5. He has not been on any other nephrotoxic agents. Kidney ultrasound shows normal size kidney and there is no obstruction to the fluid. After high dehydration with normal saline, there is still no improvement in the kidney function. And then we proceed with doing the kidney biopsy. So what will the histopathology likely show in this particular patient? So like I mentioned before in my main master figure of the drugs, antifolate drugs, that is pemetrexate and methotrexate, these are known to cause crystalline nephropathy. Let's talk about the mechanism by which pemetrexate can cause nephrotoxicity. It is internalized into proximal tubular cell, and it causes inhibition of the dihydrofolate reductase, which eventually diminishes the DNA synthesis and causes proximal tubular cell damage. And this is what we see commonly in patients who are treated with pemetrexate administration. You see the tubule here, and you can see the tubular injury. You can see some vacuolization of the tubular epithelial cells. So what is the spectrum of kidney injury happening with pemetrexate? You can see proximal tubular injury with vacuolization. You can see interstitial fibrosis on kidney biopsy. Occasionally, you can see distal renal tubular acidosis. And you can have this presentation like nephrogenic diabetes insipidus. Combination of platinum compounds like cisplatin can increase the toxicity risk. The cumulative risk profile is important. As the dose builds up, the risk of toxicity goes up. And presence of underlying CKD, again, is a very important risk factor. Prevention, B12, folate, hydration is important. And there is something which is called as thymidine rescue therapy, which can be used for severe toxicities. It basically replenishes the thymidine and helps for the DNA repair, hopefully improving or hopefully not allowing the cell death to happen. But again, it's not of a very proven therapy. Methotrexate, which is again a cousin of pemetrexate, you can very classically see the tubular injury here, and you can see a crystal which is there in the tubule, which causes more like a crystalline nephropathy. So treatment for methotrexate nephrotoxicity is aggressive hydration, urinary alkalinization, because alkaline urine will prevent the crystallization. Discontinuation of medications that inhibit methotrexate excretion, that is NSAIDs, probenecid, penicillin. And there is a particular nomogram which is called as the leucovorin nomogram or leucovorin rescue therapy, which actually prevents it diminishes the risk of acute kidney injury. But now with the availability of glucarpidase, which is available at only select places, glucarpidase can actually be used, which will help in, again, diminishing the risk of the methotrexate nephrotoxicity. Again, glucarpidase administration is also based on particular nomograms. Certain individuals will need hemodialysis to remove the unbound methotrexate level, because unbound methotrexate also causes significant bone marrow suppression. So in order to deal with that, patients are dialyzed and their methotrexate levels are serially monitored. You have to be careful with this strategy because you don't want to remove excess methotrexate, because then the cancer therapy will be compromised. Let's look at the case for you. This is a 57-year-old lady who has been treated for multiple myeloma. She has an IgG kappa myeloma and has failed several first-line chemotherapy agents. And she started on carfilzomib. Now, carfilzomib is actually a proteasome inhibitor like cortisone. 10 weeks after the treatment, she starts complaining of severe fatigue and is found to have new onset anemia and thrombocytopenia. Blood work is done, which shows serum creatinine of 1.9 up from the baseline of 0.8. Her multiple myeloma appears to respond with the decrease in the free light chain ratio. So her multiple myeloma is responding. But then she has developed this new onset acute kidney injury with new onset anemia and thrombocytopenia. The spot protein to creatinine ratio is 1. And the kidney biopsy is performed because we are unclear as to why the kidney injury is happening, even when the myeloma part is responding. So what histopathological phenotype are we likely to encounter in such a scenario? I'm going to show the pathology first, and then we'll talk about exactly what happened with this patient. So what we are seeing here is a big glomerulus. We can see the fibrin inside the glomerulus, and we can see hyalinosis of the small arterioles. So basically, we are encountering here is a systemic thrombotic microangiopathy like process. The patient has renal TMA, and with the presence of thrombocytopenia and anemia, patient has a peripheral TMA as well. So coming back to the drugs which can potentially cause TMA in such a scenario. So proteasome inhibitors are known to cause thrombotic microangiopathy, especially the drugs which we know are bortezomib, axazomib, and carfilzomib. How does thrombotic microangiopathy happen from proteasome inhibitor? There could be a downstream reduction in the vascular endothelial growth factor production. It could be because of certain antibodies which are generated against the ADAMTS13, which causes the endothelial dysfunction, or carfilzomib or bortezomib can directly injure the endothelium. So these are all potential explanations. None have been proven yet, but these are just possible explanations which can lead to a downstream thrombotic microangiopathy like phenotype in these patients. So drug-induced thrombotic microangiopathy is a very important thing when we are treating patients with cancer. There are a bunch of drugs which are known to cause this. Vascular endothelial growth factor inhibitors can cause, cisplatin can cause, calcineurin inhibitors can cause. And most of the thrombotic microangiopathy which happens in a setting of cancer could be because of the direct endothelial toxicity. In certain individuals, it could be immune-mediated or antibodies which are generated against the ADAMTS13. The toxic reactions could be dose and time dependent. It can happen with a single dose. It can happen with multiple doses based on the drugs which we are using. And like I said, it could be because of direct cellular damage. An immune reaction, it could be an idiosyncratic reaction and can happen even with the first dose. And usually the immune-mediated ones are the ones which can cause systemic injury, like presence of hematological thrombotic microangiopathy plus an organ-threatening thrombotic microangiopathy. Another important thrombotic microangiopathy which we commonly see is in the setting of hematopoietic stem cell transplant, which we also call as the transplant-associated TMA, also called as the TATMA. Now, like I mentioned before, hematopoietic stem cell transplant can have various downstream effects, which can cause endothelial cell damage, it can cause T-late cell activation, it can cause portal hypertension, decreased glomerular circulation leading to acute kidney injury. It can cause direct endothelial and podocyte damage, which can cause hypertension leading to thrombotic microangiopathy. Again, the radiation therapies which are used in priming these patients for the bone marrow transplant, calcineurin inhibitors which are used can induce thrombotic microangiopathy. So various pathways operate leading to thrombotic microangiopathy as well as an acute kidney injury in this setting. So what are the general principles in the management of drug-induced thrombotic microangiopathy in this setting? Drug discontinuation is the first thing. You stop the drug. In this patient, we stop the carfilzomib and supportive care. The data regarding plasma exchange is just limited to few anecdotal case reports. There is no randomized trial and is possibly not feasible to even perform a randomized control trial in such a setting. Eculizumab has been increasingly being used in patients who have gemcitabine-induced thrombotic microangiopathy, and it has variable results. Now, the French thrombotic microangiopathy study group recently published their data of 12 patients with the gemcitabine-associated TMA, and they were treated with eculizumab. And they demonstrated that renal recovery completely happened only in 17% of those patients, and partial renal recovery happened in 67% of the patients. Again, gemcitabine-induced thrombotic microangiopathy is a very devastating disease. It is thought that there could be a genetic predilection for developing that. However, we really don't have any particular biomarker or ways to judge if a particular patient is going to develop thrombotic microangiopathy. Now, the data regarding eculizumab, again, is very anecdotal, and it has, like I said, variable success. But it is always good to make sure and rule out an underlying complement abnormality in these patients, because you may not know if the patient underlying has a complement deficiency which has been undiagnosed, and now the presence of the cancer and or the drug which we are using to treat the cancer may trigger the complement cascade or unmask the complement issue and present as thrombotic microangiopathy, something like what we call as an atypical HUS. Going to the case 5. So this is an increasingly recognized renal issue which we are seeing in the cancer patient. So this is a 16-year-old male patient who has been referred to me for evaluation of acute kidney injury. Patient has non-small cell lung cancer and had PD-1 staining of 52%. So PD-1 and the PD-L1 staining are commonly performed for most of the cancers to see if these patients might be responsive to immune checkpoint inhibitors. So patient is started on pembrolizumab, which is actually a PD-1 inhibitor. Baseline serum creatinine is 0.9. Patient has a past medical history of acid reflux. Is on pantoprazole, and now is admitted with acute kidney injury with a creatinine of 8. Patient does not need dialysis. Patient is non-oligo. Urine analysis shows no proteinuria. However, there are 15 to 20 WBCs, no RBCs, and there is presence of WBC CAS. A kidney ultrasound is done which does not show any obstruction. What is the likely pathological entity we are going to encounter if we biopsy this patient? So we were unsure as to what was happening in this patient, and that's why we proceeded with the biopsy, which showed following picture. Now, this is a kidney biopsy, which I think most of you can see is studied with a lot of blue material there, and which is a lot of neutrophilic here are actually all the lymphocytes. You can see some lymphocyte infiltration or lymphocytic tubulitis, and you can see the third arrow, which is pointing to an eosinophil. So what we are really seeing here is very severe interstitial nephritis with some occasional eosinophils. So this is probably an idiosyncratic or an allergic reaction which is happening in these patients who are treated with immune checkpoint inhibitors. And this is being increasingly recognized now. So this is a nice study which was performed at the Mass Brigham General Hospital by Harish, where he actually looked at their database and noted that patients who developed AKI from immune checkpoint inhibitors, 61% were males. And when they dug into the risk factors for patients who develop acute kidney injury because of this particular drug, they saw that patient concomitantly being on a proton pump inhibitor increased the odds of AKI to around 2.85, which is actually a significant risk factor. Now, whether this is and we are also uncertain if it is a causation, what would be the potential reason why proton pump inhibitors would potentiate the risk of acute kidney injury from immune checkpoint inhibitors. Not just interstitial nephritis, but immune checkpoint inhibitors, they can also cause glomerular disorders. And this is a nice study which was done by Abhijat Pichlu from Toronto, who did a systematic review and meta-analysis of 27 studies and saw that 27% of these patients who had AKI or some sort of renal issue or proteinuria had post-immune glomerulonephritis and renal vasculitis. 24% of the individuals had podocytopathies and 11% had C3 glomerulopathy, which is very interesting because what I want to come to is doing the biopsy in these individuals with varying degrees of urinary abnormalities or kidney dysfunction. It's essential to perform a biopsy because that will give us more details and give us insights into how to treat the patient. This is just an outline showing how do we really approach the patient and how do we perform a kidney biopsy. When do we perform a kidney biopsy? Always make sure there are no reversible causes of acute kidney injury. Most common cause of acute kidney injury can still be hemodynamically mediated or volume depletion. Make sure the patient is not volume depleted. Remove all the offensive medications, offending medications, not offensive, offending medication. And then see if there is improvement in the kidney function. But always make an attempt to biopsy these individuals because the sooner you biopsy, the sooner you have a diagnosis, better it is for the patient because studies from interstitial nephritis data set has shown that sooner you treat these patients, or the early resolution is the inflammation and it eventually result in fibrosis. So in general, what are the principles of management of immune checkpoint inhibitor induced AKI? Risk factors, we have seen proton pump inhibitors, presence of extrarenal immune adverse events. Now, immune checkpoint inhibitor not only causes renal immune adverse events, it can cause endocrine issues, it can cause dermatological skin rashes, they can cause arthritis, they can cause pneumonitis. Now, certain patients may not develop initially immune-related adverse event in the kidney, but they will develop extrarenal effects. So patients who have developed extrarenal effects may basically are at risk of developing renal-related side effects as well, and impaired GFR at baseline. When we do a kidney biopsy, we commonly see acute interstitial nephritis. We can see a combination of acute tubular injury with acute interstitial nephritis, or you can see some de novo glomerular disorder as well. In certain instances where it is not feasible to perform a kidney biopsy, certain types of non-invasive biomarkers are being studied, like urine retinol binding protein to creatinine ratio, C-reactive protein, flow cytometry markers for B and T cell dysregulation, and serum IL-2 levels. Now, these are all studied in small studies, have not been validated yet, but an initial small validation cohort for the urine retinol binding protein to creatinine ratio has shown that elevated levels of the urine retinol binding protein are predictive of developing interstitial nephritis. And in terms of treatment, early, sooner the better. So treat early. If the steroid treatment initiation is done within 14 days after the kidney injury happens, there is increased odds of renal recovery. If it is within 3 days of initiation, it is still better. So just don't wait. If it is feasible to do a kidney biopsy, proceed with a kidney biopsy. You'll get answers sooner and you can treat the patients. Now, patients who have been treated with immune checkpoint inhibitors who develop acute kidney injury, you stop the drug. Now, the question comes up whether you can re-challenge these patients with immune checkpoint inhibitor once the AKI resolves. So is that possible? So there have been studies which have looked at it. And in various studies, depending on what study you are looking at, there is always a risk of anywhere between 15% to 25% risk of developing a repeat acute kidney injury or a repeat interstitial nephritis if if their AKI was attributed to immune checkpoint inhibitor in the first instance. Now, the American Society of Oncology, not Onconephrology, American Society of Oncology guidelines suggest that if there is a grade 3 AKI or grade 3 adverse event, the drug should be permanently discontinued and they should not be recharged. Now, there are studies which are ongoing, which are looking at the definitive risk of acute kidney injury in a bigger cohort when patients are re-challenged with immune checkpoint inhibitor. Okay, let's see case 6. So this is a 48-year-old female who has a prior history of hypertension, underwent a total abdominal hysterectomy for adenocarcinoma of fallopian tubes. Preoperative urine analysis was normal. Serum creatinine was 0.7, which is normal. Post-operatively underwent radiotherapy for over 8 weeks. 12 weeks after completion of the radiation therapy, nephrology was consulted because of very high blood pressure. Patient had dipstick proteinuria. Serum creatinine was up to 3.2. Electrolytes, uric acid, calcium, phosphorus were all normal. Hemoglobin was noted to be 12.5. Platelet count was normal. Ultrasound of the kidneys did not show any obstruction, and hence we proceeded with a kidney biopsy because of the severe AKI. And what we saw in this patient was possibly related to patient's radiation therapy. So what you're seeing in the first diagram here is the concentric hypertrophy of the arteriole, and what you're seeing here is fibrin deposition in the capillary loops, which is kind of a renal limited thrombotic microangiopathy. Remember, the patient's platelet count and the hemoglobin were not. Patient just had very severe AKI, and probably the AKI was because of severe rise in the blood pressure and the thrombotic microangiopathy like picture what is happening because of the radiation. So radiation-induced kidney injury can present with various manifestations, and it can again affect various compartments of the kidney. It can cause vasoconstriction leading to hemodynamic injury, fibrinoid necrosis of the arterioles, hyperplastic arteriolitis, which we also called as the owning skin appearance. It can cause podocyte injury, it can cause endothelial injury, mesangiolitis, present as thrombotic microangiopathy, and cause severe diffuse acute tubular injury. So practically all compartments of the nephron can be affected because of radiation. It's a very interesting to see the timeline in which the radiation can cause kidney manifestations. So acute radiation nephritis happens within first few weeks after initiation of the radiation therapy. And chronic radiation nephropathy can go on for years actually. Now, patients with acute radiation nephritis may present with malignant hypertension, but sometimes even after the completion of therapy, patients can still develop malignant hypertension. And some patients may have these benign grumbling hypertension, which eventually gets labeled as essential hypertension. So it's very important for us as nephrologists to understand the various manifestations which the radiation can cause to the kidney, because it has direct implications on the care. Let's see case 7. So this is a 67-year-old male who failed treatment for CLL and admitted with now worsening leukocytosis. His WBC count is 78,000. Baseline creatinine is 1.4. Patient is hydrated, and serum creatinine trends down. He started on venetoclax, which is one of the monoclonal antibody which are used for treatment-resistant CLL. 8 hours after the first dose, the intern calls you concerning for the labs. Potassium is 7.5, which is very, very high. Serum phosphorus is 8.2, which is also high. Serum calcium is 7.5, which is low. And patient is non-oliguric at this point of time, but after 8 hours, the creatinine is 1.8. So patient has a new onset acute kidney injury. Now, this is a very common scenario which we face on the oncology floor. A classic picture of acute kidney injury, hyperkalemia, hyperphosphatemia, low calcium. I have not mentioned the uric acid levels here. Let's assume the uric acid levels were also high. So this is a slam dunk diagnosis of tumor lysis syndrome. So what happens in tumor lysis syndrome? So in tumor lysis syndrome, as you can see in the figure, there is accelerated breakdown of these cells, and through the purine pathway, there is increased generation of the uric acid. And the uric acid normally gets converted into allantoin, which is thrown out in the urine. So what happens because of the tumor lysis syndrome, all these uric acid crystals, they get bound to the Tom-Hirschfeld proteins and can cause severe obstruction the tubular lumen. So also when there is cell breakdown, there is release of potassium, which causes hyperkalemia. So this is the classic picture of tumor lysis and tumor lysis syndrome. And we classically describe the tumor lysis based on the Cairo-Bishop classification as just presence of lab diagnosis of TLS and clinical diagnosis of TLS. And the table is self-explanatory. So lab diagnosis is patient is not having any clinical manifestations, but just lab derangement of particular electrolytes. And when patient has uh, manifestations like arrhythmias, seizures, or patient becomes dialysis dependent or develops oliguria, is a clinical TLS. So what are the cancers which are at risk for developing tumor lysis syndrome? Any cancer which has a high cell turnover or high tumor burden is at risk of developing TLS. So non-Hodgkin's lymphoma, Burkitt's lymphoma, acute myeloid leukemia, childhood acute lymphoblastic leukemia. And particularly any particular treatment can actually induce cell breakdown and cause tumor lysis, which are using for the newer drugs which are being used for chemotherapy, like venetoclax, anti-CD20 monoclonal antibodies, even immune checkpoint inhibitors like nivolumab and pembrolizumab, certain cyclin-dependent kinase inhibitors, and newer therapies like the chimeric receptor therapies, that is the CAR T cell therapies, are known to induce tumor lysis. And this is just a nutshell about the prevention of tumor lysis and its treatment. Most important thing is hydration. Pre-treatment with allopurinol used to be the standard of care. Now, in certain cancers where childhood acute lymphoblastic leukemias, pre-treatment with RAS buricase is utilized. And if you really look at the data from the pre-RAS buricase era versus the post-RAS buricase era, the incidence of requirement of dialysis in these patients has significantly come down. And in terms of treatment, supportive treatment, manage all the electrolyte imbalances, watch for needs for dialysis, look for any evidence of oliguria. Presence of oliguria, again, is a bad prognostic sign where it means that you probably might have to start patients soon on dialysis. And conventional hemodialysis is preferred compared to the slow therapies, especially when you have acute electrolyte distress. I'm just approaching to the end of my talk, maybe 5 more minutes. I'm going to talk specifically about this emerging newer therapy, which is called as the CAR T cell therapy, which is being used in certain types of cancer, especially the hematological cancers. And if you have read the new NEJM paper, CAR T cell therapy is also being used in the treatment of certain immunological disorders, especially rheumatoid arthritis and SLE. So this is a 56-year-old patient who has history of B-cell lymphoma and is being planned to receive the AXI-CAPTA gene, which is actually a formulation of CAR T cell, which is genetically engineered. The hematologist is very concerned and asks for a nephrology consult preemptively before starting this agent. So what is the most common toxicity the hematologist is worried about when they are treated this patient with the CAR T cell therapy? So this figure actually shows what CAR T cell is and what CAR T cell therapy really means. So basically, peripheral blood is collected from the patient. The T cells are isolated, and these T cells are then genetically engineered, and that's how they form the CAR T cells. So this is the chimeric altered receptors, which are genetically engineered T cells are reinfused back into these patients. So now these activated T cells actually go and attack the cancer and try to kill the cancer. But then what happens is, once you inject these CAR T cells in certain, maybe 15 to 20% of the patient, there is a cytokine storm which happens because of sudden inflammatory reaction which happening in them, causes severe inflammation, hypotension, hypoperfusion, sudden cardiomyopathy, which causes acute kidney. So patients can develop hemodynamically mediated prerenal acute kidney injury, going into the spectrum of acute kidney. Now, the CAR T cell therapy is being studied more and more, and its renal effects are being studied. And this is a study published by Shruti Gupta recently in AJKD, which looked at various case series from two major cancer centers where patients were treated for diffuse large B-cell lymphoma. And the incidence of acute kidney injury after the CAR T-cell therapy was 19%. And the presence of cytokine release syndrome in these patients was negatively 85%, which is very impressive actually. And because of third spacing and capillary leak syndrome type picture, patient develops severe hyponatremia, hypokalemia, and hypophosphatemia. Management, again, uh, pay attention to the electrolytes, uh, treat the hypokalemia, treat the hyponatremia, treat the patients with IV fluids, and certain types of agents like the IL-6 blockers, which like the tocilizumab, which has been used in treatment for the cytokine storm, which happens in COVID-19 patient, has found to be useful in these patients also. Patients can be treated with steroids to bring down the inflammation. Very rarely patients require dialysis in this scenario. This is usually a self-limited condition, but in 15 to 20% of the patients, we may need to treat them with these other therapies. This, I think, is the last case. So this is a 65-year-old patient who has been diagnosed to have lung cancer. So now the oncology field has progressed to a very precision medicine, um, like is a very precision medicine based approach. So all these cancer histopathology specimens are stained for certain type of genetic mutations, and based on those genetic mutations, targeted therapies can be given. So this particular patient underwent genetic testing for lung cancer and was found to have a MET exon 14 skipping mutation. There are therapies which specifically target this MET exon 14 skipping mutation. So his baseline creatinine is 1.2. He started on a drug called as the capmatinib, which is a MET kinase inhibitor, which is specifically used in this particular mutation. 4 weeks after the treatment started, patient's creatinine went up to 1.8, and that's the time when patient was referred to me for evaluation. Urine analysis is normal. There is no proteinuria. There are no casts which are seen. So we did a cystatin C level on this patient. So we are fortunate that our lab does cystatin C for us. The usual turnaround time for cystatin C is 3 to 5 days. In this patient, the cystatin C was normal. His capmatinib was stopped. His serum creatinine came down to 1.2, and a re-challenge was given. His creatinine went up to 1.7, but with a normal cystatin C level. This time, patient's capmatinib was not stopped, and we just continued to monitor his cystatin C levels. So what I want to highlight here is the concept of pseudo-AKI, or what we call as the artifactual elevation in the creatinine because of certain types of agents. Now, it's very important as a nephrologist, when the oncologist, they seek our opinion to ascertain that this acute kidney injury is a real acute kidney injury and not a pseudo-AKI, because we don't want the patient to be deprived of their essential chemo or targeted therapies. Now, there are various drugs which are new on the market now and which have been FDA approved. Before that, I'm going to tell you one thing is how does this drug particular, the capmatinib, how does it cause a pseudo-AKI? So what it does, it inhibits the anion and the cation transporters which are there on the proximal tubules, various receptors, and it interferes with the secretion of the creatinine, causing an increased level of creatinine. Now, these are the drugs which have been FDA approved, which can cause pseudo-AKI. A few of them are the anaplastic lymphoma kinase inhibitors, also called as the ALK inhibitors, CDK inhibitors, the PARP inhibitors, and the MET tyrosine kinase inhibitors. Now, this is a lot of words, a lot of complicated drugs. But what is important to remember is the class effect of these drugs, that they can cause pseudo-AKI. But then there are certain types of drugs which can also cause real tubular injury. So be on the lookout. If you see the cystatin C being abnormal as well, that should prompt us to look for alternative causes and even consider doing a kidney biopsy in these. So remember, with these particular agents, not all elevations in the creatinine is an acute kidney injury. Look for pseudo-AKI, but also make sure patient does not have real AKI. So I'm wrapping up with my talk now. This is just a recap about the various drugs, what we looked now. So remember this figure, remember the various compartments on which the drugs act. There could be drugs which are acting and causing kidney injury because they act at multiple sites, so which is very important to remember. Certain teaching points, it's important to recognize the spectrum of acute kidney injury in patients with cancer. So there is a complex interplay between the cancer therapies, patient-specific factors, treatment-specific factors. The newer targeted and the immunotherapeutic drugs, that is the immune checkpoint inhibitors, have really revolutionized the treatment of cancer and also has improved the survival of these patients. And with more survival, we are seeing more of survivorship-related issues like increased risk of hypertension, proteinuria, cardiovascular increased risk. So we need to pay attention to these things as nephrologists. There should always be a constant discussion between an oncologist and a nephrologist because we are not trained in these therapies. I always like to talk to my oncologist once I see the patient and make sure that I'm not inadvertently giving a wrong message to the patient and not stopping any of their therapies. It is important to understand the various phenotypes, like I showed, and the various drugs which are act on the various compartments. And remember the concept of pseudo AKI, especially with the newer targeted therapies. We don't want to give a message to the oncologist to inadvertently stop the important drug which is being given to the patient to treat their cancer. Just a few resources which I have shown even in my previous talk. We have published this two-part issue with nearly 25 manuscripts on advances in onconephrology. And we were part of this online curriculum for onconephrology through the American Society of Nephrology, which is available for all the ASN members. Thank you. We are open for discussion. We entertain questions.
Thank you so much, Prof, for that in-depth presentation. I must say, onconephrology is something that, as you correctly said, is not taught in conventional nephrology. And that is why it's actually a specialty on its own. But we're grateful that you did give us an insight on the topic in itself. So the floor is open to questions. The first question is from Professor Kajiro from Northern Tanzania. So he asks, he's also a nephrologist. He asks, hypertension induced by the VEGF inhibitors. May you repeat again how this becomes long-standing hypertension despite stopping the medication?
Yes, Professor, a very, very good question, actually. And we are still trying to understand the various molecular mechanisms through which hypertension can happen in these individuals. So in my clinical practice over the last 5 years, since I have started seeing onconephrology patients, I have seen various spectrums. So I'll give you a few examples. I see patients who are treated with a few doses of the VEGF inhibitor. Nothing happens to the patient. They don't develop hypertension. There are a few subset of patients who develop both hypertension and proteinuria. And there are certain subsets of patients who develop either hypertension or proteinuria. So we really don't have any clear-cut idea as to which patients are going to have which presentation. That's one point. The second thing is, once a patient is treated with the VEGF inhibitor, as the VEGF receptors, they downregulate, it may take a few days to few weeks, depending on which agent is being used. Now, in my clinical practice, I have at least 3 whose VEGF therapy has been stopped. Initiation of that therapy. But now they are hypertensive. So what is really causing hypertensive or the pro-hypertensive effect in these individuals in spite of stopping the drugs is a very good area of research, and we still really don't have a good answer to that. But it has been seen, it has been observed in clinical practice. But essentially, you treat these patients like what you would treat them like your all essential hypertensions or patients with diabetes and hypertension with RAS blocker.
Thank you, Prof. Another question from Dr. Azael Howard. In case 7 that you presented, I think it's probably case 5, the patient with tumor lysis syndrome. Apart from cancer-specific factors, are there any patient factors that may predispose more to tumor lysis syndrome or predict their outcomes?
Yes, exactly. I mean, the total body water distribution of the patient is important. Um, because if you have a higher body of like if the total body of distribution of water is more, the dilution of all those generated electrolytes would be that's one point. Advanced or a patient specific risk factor. Again, other issues like presence of diabetes, hypertension, underlying kidney disease are again other patient specific risk factors. Which is kind of again similar for any other AKI or a community acquired AKI, which can happen in our.
All right. Thanks. Thank you, Prof. While we're waiting for some more questions, when you were presenting with regards to the pseudo AKI, so while you were presenting, before you answered my question, because I had a hypothetical question that was coming, why would the creatinine be elevated? So I was thinking, is it related to the way the creatinine is measured? So the enzymatic process versus the Jaffe process. We know that the Jaffe reaction has got interactions, but obviously you answered the question by saying that it inhibits the anion transporters and the cation transporters. But is there a link that this could be also a possibility that it is interfering?
This is possible. It is possible, but at our place we have a standardized way of checking creatinine now. So I think it is all enzymatic way of checking creatinine. So like the previous Jaffe's method, most of the labs in US have abandoned using the Jaffe's technique, and it is the enzymatic technique, which is. But very good question.
Not sure if the panelists have any questions. Dr. Lloyd?
Because there's a lot of these drugs, we don't encounter this in Africa, it's all new to us. And I think the whole system, the whole subject is like quite complex and needs histopathology and things like that. Huh? What is your view? I mean, will this therapies come across this side? Because it's so complex. Oncology itself is so advanced in your setting, very, very advanced. It's so complex, I'm seeing, from what we studied and what.
So you're right. I mean, the oncology, exactly. I mean, the oncology therapies have really changed the complete paradigm of cancer treatment over the last 2 decades. And now, I mean, you and I both come from India, and we know things back in India have changed significantly, even in terms of cancer therapies, where doctors or nephrologists are more and more seeing such type of nephrotoxicities now. So I think it's just a matter of time that it is going to come to African continent, and oncologists there will have, or the patients will have the benefit of getting these drugs. And eventually, as nephrologists, we'll be seeing more and more toxicities with these drugs. So I think it is just a matter of time that we are going to see that.
It is really complex. I mean, the drugs that are coming on board, the usage in the various malignancies, it is certainly stunning now, and more coming. A lot of, and histology is, I think, a key thing. The testing that is there as well. So it's a wonderful session and really covered a lot. So thank you very much. Phenomenal. Thanks a lot.
Okay. Thank you, Dr. Lloyd. Thank you, Prof, for that lovely talk. Questions?
Thank you for having me.